So one of the things I wanted to do today was give you a bit of an introduction about Dr. Venessa Tsang and talk about the presentation she's about to give. So we're delighted that she's prepared a presentation for us today. She will be joining us live for questions. Dr. Venessa Tsang is a clinician researcher, and she's currently working as a specialist endocrinologist at Royal North Shore Hospital. She's also a senior lecturer at the Northern Clinical School, Faculty of Medicine and Health at the University of Sydney. She's a busy clinician, and she's looking after patients with adrenal, thyroid, and pituitary conditions, as well as diabetes and bone disease. So Dr. Tsang is an active researcher and with primary expertise in the intersection between endocrinology and cancer. And she's also involved in medical education. Dr. Tsang is the endocrine co-chair of the Northern Sydney Local Health District's Diabetes and Endocrinology Network, and she's currently a supervisor for MD student projects and PhD students. So we thank Dr. Tsang for contributing her time to help us understand more about our condition, and I'll hand over to Linda and Dr. Tsang.
Hello, my name's Venessa Tsang. I'm a senior lecturer at the Northern Clinical School in the Faculty of Medicine and Health Sciences at University of Sydney, as well as a staff specialist in endocrinology at Royal North Shore Hospital. I'd like to thank the Australian Addison's Disease Association for inviting me to talk to you about what's new and old in Addison's disease at the annual seminar. We've been delayed from last year, and hopefully we're all adapting to the virtual meetings and are still able to share information. I am going to be talking about some old ground as well as new information, and after this recording we'll be talking to some of you face-to-face about and answering some of the questions you might have. So the information discussed is the opinion of me, the speaker, but I have no other relevant disclosures related to this talk. I'd like to also acknowledge at the upfront the Head of Department of Endocrinology at Royal North Shore Hospital, Rory Clifton-Bly, as well as my colleague Lyndall Takon, who have shared some of these slides with me, as well as, most importantly, the endocrine nurses, staff and other nurses at Royal North Shore Hospital who have been instrumental at looking after a lot of you who live in our area health service. So I'll be covering some ground on looking at adrenal function and anatomy, causes of hypoadrenalism, investigations of Addison's disease, management including that of stress dosing, emergency presentations, and some new information and future directions on the management of Addison's disease. So adrenal function and anatomy. So as you know, Addison's disease was initially described by Thomas Addison in 1855. They discuss the local effects of disease on the suprarenal capsules, and you can see in these beautiful drawings that they made at the time that the adrenal glands were described and discussed, and the causes of why this might be already well known 2 centuries ago. And this is a picture of Thomas Addison, as well as some famous faces that have had Addison's and still held office, such as JFK. Jane Austen was also thought to have Addison's disease, amongst other people. The adrenal gland is adjacent to the kidneys, which are the renal, also known as renal and hence adrenal. They're usually about 5 grams and can be V, Y or T-shaped. And this is the histopathology, so looking at it under the microscope, what it looks like. So I hope you might be able to see my cursor. So looking at it in sort of a microscopic detail, there's 2 main components of the adrenal gland. So there's the outside sort of capsule, as well as fat tissue or adipose tissue outside, but it contains the cortex, which is the outer half, and the medulla, which is inside. And right in the middle of that is the blood vessels taking some of the hormones away. And each of these layers are important because they secrete a distinct different hormone. And that's what's interesting about this gland, is that it secretes a whole lot of different things that do different things in the body in the same little 5-gram gland. So from the outside in the cortex, there's 3 other layers called the zona glomerulosa, which secrete the mineralocorticoids or aldosterone. The middle, which is the zona fasciculata, which secrete the glucocorticoids. And the inner layer, the reticularis, which secretes the androgens, including DHEA, DHEAS, and gestational. The middle layer, which is the juicy medulla or the central part, contains chromaffin cells, which are of different origin to the cortex, and they secrete adrenaline and noradrenaline. Each of these hormones do slightly different things. Mineralocorticoids and aldosterone are involved in salt and water retention, and so they help maintain blood pressure. And so lack of this can cause problems with sodium or salt levels as well as blood pressure in patients. Glucocorticoids is what we mostly replace. So this includes prednisone, dexamethasone, hydrocortisone, cortisone. So when people are deficient in this, they again drop their blood pressure significantly, but also have low heart rate, glucose level, and just feel generally terrible, as I no doubt have to not tell this particular audience. We'll touch base a little bit on androgens as well. So in men, androgens also secreted elsewhere in larger levels, but in women, most androgens are secreted either in the ovaries or in the adrenal glands, and these may or may not need to be replaced, and we'll talk through the evidence of some of that. And finally, adrenal and noradrenaline tend to not be affected in hypoadrenalism unless it has been a bilateral adrenalectomy. And even then, there are other places in the body that do secrete adrenaline and noradrenaline, so we don't tend to replace those hormones. So normal adrenal glands look like this. And so this picture on the left is what the adrenal glands look like, and when you cut them in the middle, you can see that there is the medulla, or the central bit that you can see on that picture. And when we do imaging, this is a zoomed in version, but the arrows indicate the right-hand side and the left-hand side, the adrenal glands. They can look like little, Ys and Bs, as we sort of discussed, or T-shapes. When there's nodules and it's increased in size, it does look quite different and large, and look more like, a circle where there's nodules. But as you also know, the adrenal gland is part of the big adrenal system, and there's different hormones that include that are secreted in a lot of these glands. So specifically for the hypothalamic pituitary adrenal axis, the important components and hormones are the hypothalamus, which secretes CRH, which then tells the pituitary to secrete ACTH, which then under stress will tell the adrenal gland to secrete cortisol. And this is all under feedback, a negative feedback mechanism, where if there's excessive cortisol level, there will be a feedback to suppress ACTH secretion, and vice versa. If there's very low cortisol level being secreted from the adrenal glands, the ACTH will be high, as is the case for primary adrenal insufficiency. So if there's a problem, either an autoimmune or from trauma or surgery to the adrenal glands, the cortisol will be low, but the ACTH will be high. Whereas if there's a pituitary problem, both the ACTH and the cortisol will both be low. So we'll go through this again in more detail with the case. And also to remember, the cortisol secretion in a normal person is under a circadian rhythm, which means that it's highest first thing in the morning. In fact, it's sort of the hormone that kicks you out of bed, and it's the one that wakes you up. And we often test for deficiencies where it's highest. So first thing in the morning is when often you are told to go and get a blood test if we're testing for lack of hormone. Whereas it starts drifting low, it sort of may account for some of the afternoon slump that we all feel. And then it's lowest at midnight, so that if we're testing for excess, so we're wanting to see whether someone has too much cortisone in their system, we test it with salivary sampling at midnight, because if it's still high at that stage, then it's not normal. The dotted line is what proposed replacement doses might be. So we usually, if we have the short-acting steroids, give it 3 times a day at those particular time points, but it depends on when in the day one wakes up. It's never exactly the same as your own cortisone secretion, and that may sometimes account for some of the symptoms people have. This very complex diagram we should not need to remember, but I think there were questions with regards to what the adrenal glands does secrete and how it all works. So it all comes from cholesterol, and then when you use a whole number of these, which are enzymes within the adrenal gland, there sometimes can be deficiencies in these from inherited defects. They then go down 3 main pathways that make those 3 hormones that are in the 3 layers, including aldosterone, cortisol, and testosterone. So let's get through to a case, and something that may be familiar to some of you. So the case one is that of a 43-year-old man who is a barista. He's well, no previous medical history, and is on no regular medications. He lives with his partner, is a non-smoker, drinks no alcohol, and has no over-the-counter preparations or illicit drugs. However, he's had 6 months of general fatigue and lethargy, worse over the last 4 weeks, and acutely he's presented to the emergency department because of a 10-day history of escalating nausea, vomiting, and diarrhea. He was worried there was gastroenteritis, went to see his general practitioner, who went, "Oh, you look terrible, go into the emergency department." Upon examination, he was noted by the emergency department that he had pigmented skin. He'd had some weight loss because of his recent gastro, but also just the general malaise and fatigue over the last few months, low blood pressure, low glucose level, and his sodium level was quite low, which I'll present in the next few slides. And there was a trigger, which was that he'd had the vomiting and diarrhea recently as a presentation for his adrenal crisis. So you can imagine this is something that some of you may have encountered or heard about before. Now, this is a real patient with a particular case. This is my hand, and this is the patient's hand. And he's of Caucasian background. And as you can see, he has quite pigmented skin. There can also be pigmentation, particularly of the mucosa, that's quite marked. Pigmentation of previous scars, as well as general pigmentation of the face, as you can see here. So here's the answer. He had some blood tests drawn by a very clever emergency physician, and the cortisol level, which should generally be at least in the hundreds, 200 to 250 nanomoles per litre, was 55, very low. And CTH level upper limit of cutoff is 10 nanograms per litre is quite elevated, and it is suggestive of a primary adrenal problem because the cortisol is low and the ACTH is elevated. Importantly, his thyroid function test was also done at the time, is all in the blue normal range. So how is he treated? So recognition is the key. So doing the appropriate blood test is really important. Thereafter, he needs stress dosing because he's very unwell, and so he needs intravenous hydrocortisone of 50 to 100 milligrams, depending on how low his blood pressure is and how unwell he is. And this needs to be done fairly quickly. Pretty much as soon as you've sort of given the hydrocortisone, almost at the end of the needle, patients will improve and get better. It's also really important to involve the multidisciplinary team to ensure that there is adequate education on what Addison's disease is and hyperadrenalism is, education on stress dosing, education on injections of hydrocortisone solid cortical activar, which we'll talk about in a sec. And because it is a primary adrenal problem, we do add mineral corticoids in a few weeks' time. I'm trying to find the cause, and there can be many reasons for why someone might have primary hyperadrenalism. The very common causes include Addison's disease, which is actually where you have an autoimmune condition causing adrenal insufficiency, and you can test for some of those antibodies. More uncommonly in Australia, but more common overseas, are infections. So you can have bilateral infections, such as tuberculosis, that can cause this, and also certain other medical conditions, such as hemorrhages into the adrenal glands. So here it is again. Here's my table about the pituitary versus the adrenal gland. So as you recall, the pituitary secretes the ACTH and the adrenal glands cortisol. If there's a pituitary deficiency, which can also sometimes happen, this is termed ACTH deficiency or secondary adrenal insufficiency, because we're just trying to confuse everyone with a primary and secondary. This suggests that there may be some pituitary or hypothalamus disease, and this can be anything from infections, tumors, and medications. And you basically need to consider giving steroids and medications. Adrenal is primary adrenal insufficiency, so it's a primary problem with regards to the cortisol. And this can be, as we discussed already, an autoimmune, which is what Addison's disease technically is, infections, bleeding on both sides, tumours, so particularly if it's metastasized from elsewhere or spread cancer from elsewhere, surgery, and medications. There can be associations with particularly the autoimmune endocrinopathy or Addison's disease. There's two main types that are recognized and their association. So type 1 has a known mutation in the AIR gene, and they're usually associated with, as well as Addison's disease, mucocutaneous candidiasis, or a fungal infection, particularly in the esophagus and gastrointestinal tract. Hypoparathyroidism, or low calcium levels and low PTH levels, and less commonly other problems such as low testosterone estrogen levels, type 1 diabetes, and underactive thyroid. Type 2 is more polygenic, so lots of genes can contribute to this, and those are the types of autoimmune conditions that are associated with it, because people that have one autoimmune condition are more likely to be associated with other autoimmune conditions than others, but there are known associations with Addison's disease. And these are worth thinking about, and if the patients aren't feeling so good, have a think about and testing for them, particularly things such as celiac disease, hypogonadism, and screening for type 1 diabetes and thyroid disease where needed. So when one is suspecting hypothalamic pituitary or adrenal problems, the sodium and potassium levels in the blood should be looked at, as well as a defining test, which is the cortisol level and ACTH level, as we said, because that can pinpoint whether it is likely to be the adrenal or the pituitary or hypothalamus that's the problem. Then they may want to stress the patient with a thing called a synachron test, where a patient's injected with a synthetic version of ACTH to see what the cortisol response is, whether there's a borderline result. Or to test the pituitary and hypothalamus, we make the patients have really low glucose levels, and that generally is supposed to induce a stress response with an elevated ACTH. And neither of those are happening, then it suggests that there's a problem with the whole feedback loop and with the hypothalamic pituitary adrenal axis. If the cortisol level at baseline is already pretty low, we generally don't need to go on to do those two stress tests. Let's have a look at a second case of pituitary failure to contrast the first of the adrenal failure. So this is a case of mine of a 71-year-old retired high school teacher with a previous history of blood pressure and cholesterol problems. He unfortunately was diagnosed with metastatic melanoma, and as is often the case now, we now have on the PBS or Medicare available combination immunotherapy treatment, which he started very successfully with resolution and regression of a lot of his tumours. However, 2 months into treatment, he developed a really bad headache over a few days, and then 48 hours later developed nausea and vomiting and was really tired. So often these patients, when they're having immunotherapy, feel tired at the time of the infusion. This was way worse than anything we've ever seen. And these are his blood tests, and just so that you can see them and not that you have to remember them, but just to know. In contrast to the previous case, this cortisol level was undetectably low at 9 o'clock in the morning. But in addition, his ACTH level on this assay cut-off was 12.1. His is low rather than high, suggesting a problem higher up in the pituitary or hypothalamus. He also had thyroid deficiency with inappropriate low TSH and T4 levels. T3 level has been maintained, but this is suggestive that there is a problem at the pituitary level of for the thyroid. His testosterone level was also low, again with an inappropriately suppressed FSH and LH, which are all hormones secreted by the pituitary gland, whereas growth hormone, IGF-1, prolactin, also all hormones that are secreted by the pituitary, are maintained with a normal range for now. He had an MRI scan soon after, and this is actually an image of the brain from the inside. This is his eyes and Albert's nose, and this is a cross-section through the brain. And the circle here is actually the pituitary gland, and believe me, it is actually quite swollen with a very swollen stalk. And this is for comparison in normal pituitary, and the main thing you can see is that the pituitary gland, even though they're different people, is much smaller and the stalk is much narrower there. The pituitary gland has two components, a front bit or the anterior part and the posterior part, and it secretes a whole lot of different hormones. So the anterior part secretes ACTH, which, as you know, and we've discussed, tells the adrenal glands to secrete cortisol, but it also secretes thyroid stimulating hormone, prolactin, growth hormone, luteinizing hormone, follicular stimulating hormone, all which do different things at different parts of the body. So it really is sort of a conductor of an orchestra of the endocrine glands in the body. The posterior pituitary secretes ADH and oxytocin. These have an impact in, again, water and salt retention, and oxytocin's more in breastfeeding and childbirth. So you can see all of these things that are being governed and looked after by the pituitary gland. These all potentially can be affected if there's some disease, a process happening with the pituitary gland. But specifically, this is now becoming a more and more common cause for hypoadrenalism, hypophysitis, or inflammation of the pituitary gland. So hypophysitis has always been a medical problem for a long time, but it generally has been quite rare and generally autoimmune, so similar to the autoimmune Addison's disease that you can get. But now these new drugs that are treating cancers activates the immune system, causing new autoimmune conditions shortly after the initiation of these drugs. And it's more likely when people are on multiple versions of these immunotherapy drugs or high doses because their particular cancer is more widespread. So these are sometimes called immunotherapy or immune checkpoint inhibitors. They're being used for a whole number of cancers, and this is by no means an exhaustive list, but sort of the first few, including melanoma, kidney cancers, lung cancers, lymphoma, amongst others. And there's a lot of clinical trials ongoing for testing of other types of cancers as well. And basically, these drugs can affect the pituitary. For some reason, isolated pituitary dysfunction. A lot of the time it affects ACTH only, but can also affect the thyroid, which controls your metabolism. And Professor Eastman is going to talk a little bit about, as well as the testosterone, estrogen secretion. Let's move on to talking about how we manage these patients and adrenal replacement. So as you can see, basically we want to replace what's missing. As detailed previously, the medulla is not really much affected, but the cortex needs replacement. So in the cortex, the fasciculata secretes glucocorticoids. And so the glucocorticoid replacement that we have available we'll discuss. And the glomerulosa has mineralocorticoids, and we'll talk about those as well. So generally, the glucocorticoids that we have synthetically that are available are listed there, and their differences are basically whether they are short-acting, intermediate-acting, or long-acting, and what suits a particular patient. General teaching is that we should try and go for the short-acting guys, the hydrocortisone, cortisone acetate, but you need to take them 2 or 3 times a day in general in a lot of cases. Otherwise, it drifts out, so it lasts about 4 or 5 hours and will be quite tired if you take it first thing in the morning. Prednisone lasts about 12 hours, but it's quite variable in terms of its absorption and metabolism in different people. Some people it is convenient, especially those patients that have been on immunotherapy. They have oncology treatment ongoing, and they may already on prednisone to treat some of the other side effects. So I do use this for some patients. It has less mineralocorticoid activity, but for pituitary dysfunction, you don't usually need to give them the mineralocorticoid activity. Dexamethasone is much longer acting. It may last several days, and it's this column talking about the relative glucocorticoid effect is just basically to show you that there's actually differences in doses. So 1 milligram hydrocortisone is not the same as 1 milligram of prednisone or dexamethasone. But dexamethasone we often use for people who've got, again, oncology problems because it lasts a long time. It helps decrease swelling for tumours, and it also helps stimulate appetite. But in people with Addison's, we tend to avoid it because it gives those patients too much steroids, particularly overnight. And it has very little mineralocorticoid activity. So if a patient has adrenal problem, you then also need to replace a mineralocorticoid. And their own one that's secreted by endogenous is aldosterone. We can give that, but often the easiest version is fludrocortisone at 1/2 or 1 tablet per day. What is the appropriate dose? So usually it needs to be done on an individualized basis, but weight does have a bit of an impact on it. And so this is a paper that was written a few years ago in clinical endocrinology, where there is a suggestion on weight-based titration of doses. Now, this column is sort of what the total daily dose should be and what the first, second, and third doses throughout the day are. And as you can notice, most of the regimens give the biggest dose first thing in the morning when a patient wakes up. Second dose around midday, sort of a little bit half of that generally, and a smidge in the evening if they need to. And we suggest generally not taking it too late in the day, not past 4 or 5 p.m. if they can help it. But again, everyone metabolizes and absorbs these tablets differently, and we have to start off with a particular dose and then work up whether that particular regimen is best suited for them or not. Because with excess replacement, there are various problems. So there is a medical condition of excess cortisol secretion called Cushing's syndrome, where they manifest with similar conditions. In hypoadrenalism or Addison's disease, we're replacing what's missing rather than giving excessive amounts like one would in Cushing's syndrome or using it for rheumatoid arthritis or other conditions. But if you give too much, these are the things that we start watching out for. So elevation in blood pressure, elevations in glucose and diabetes, thin skin, easy bruising, increased weight because of increased appetite, particularly centrally, so increasing the waist and hip ratios, and also increasing rapid loss of bone, so you're more likely to have osteoporosis. So being aware and keeping an eye on these in these patients, I think, is quite important because for most of the patients that have hypoadrenalism, it's not a transient thing, it is something that's lifelong. Particularly with autoimmune Addison's disease, they're diagnosed quite young, and so they have a lifetime of steroid replacement, and these may catch up with them because our steroids are not exactly the same as the steroids that you would secrete yourself. The Endocrine Society of Australia, now on their website called Hormones Australia, has a standardised form that I now give to all of my patients for sick day management of patients on glucocorticoid therapy. So we'll put the names down, diagnosis, and my contact details. But what's really nice is that you can put down exactly what tablet they're on, because as you know, they're not all of equal potency, what the usual doses are, and write down exactly what the issues may trigger what in adjustment of doses. So generally, for example, mild trivial illness, exam, stress, bereavement should not require any dose adjustment, but it is at the discretion of the treating doctor. So I would say, you know, if they're on hydrocortisone 2010, you would stay on the same. But if they've got a low-grade fever, you would suggest generally doubling the dose for at least 2 days or until they feel better. And high fevers and diarrhea or fevers above 38.5, tripling the dose for at least 3 days. But really the most important thing to note, and you should all know this already, is if they have vomiting or persistent diarrhea and persistently raised or even normal temperature but have gastrointestinal problems, the oral doses is not going to be really that well absorbed. And so hydrocortisone injection will be required either by self or more easily heading to the GP or emergency department. And really basically the most important thing is to know where things are. Now we're all in COVID lockdown at the moment and should know who our main contact are from a medical point of view, but we never know what's going to happen, whether there'll be more strict lockdowns. We should always seek medical attention if there is worry about adrenal crisis, because it is a life-threatening thing that can change within a short period of time, particularly when there's gastrointestinal infections. But saying that, it's also really important to make sure that patients have this plan and are up to date with it. Always seek medical attention if you become ill. And once the illness is over, then to reduce down the dose within a few days. Other medications such as mineral glucose should need to be adjusted, and one would generally, I would talk to the patients at each follow-up appointment to see what extra doses they've had. Having a medical alert bracelet is useful, and always have a list of all of your other medications so that patients can present this to the emergency department if they're not well known to them. On the third page of the sheet is something also quite useful, I find, because patients always ask me, as well as surgeons and anaesthetists, how much should I actually increase the dose by? And there's our standardized version. So there's recommendations on how it should be, but depending on what the surgery is, whether it's major surgery, moderate surgery, or minor procedure, there is a suggestion of how much stress dosing around the time of the procedure should be, and afterwards, how much to double it for. So it's nice to keep this around and so that you can have. And this is also published guidelines. This is based on glucocorticoid replacement and adrenal insufficiency. But basically that form from Hormones Australia, I think is quite useful. And again, I don't need to tell this particular audience that there is this not super user friendly, but nevertheless injectable version that one can use on their own. On the Pfizer information, there is actually a video that's been filmed by the endocrine nurses on how to administer it. And I think it's quite useful to review prior and also to have on your phone. So usually you can actually text this number and text Solucortef to them, and then they'll text you back the link for the video straight away. Because I think in the heat of the moment, it is a kind of a fiddly thing where you've got to push this bung down, mix the saline and the hydrocortisone and pull it out and inject it. So it is, if there's not too much going on and there is a concern that there may be ongoing gastrointestinal infection, to head to see your local doctor to have this infection if you're not certain. We who work in New South Wales Health are really aware of the fact that sometimes patients have told us stories where there's been delays of in the emergency department because they are busy, they are dealing with a lot of emergencies. And so an initiative that has been started at some hospitals, initially I think at Royal Prince Alfred Hospital, but we're trying to make this an adrenal alert, a New South Wales health-wide thing where if patients are admitted to the emergency department, we then have a little flag to say this particular patient is on long-term steroids, because it does go for everybody, whether they have pituitary problem, adrenal problem, hypothalamic problem, or even if they've been on long-term steroids, their own stress response is not going to be adequate. And so all adrenal insufficient patients should have a rapid assessment, not been made to sit in the waiting room for a long time. And consider an immediate dose of hydrocortisone so that they give that if it hasn't already been given. Rehydration, because often patients are quite dry, and then try and find the cause and treat the presenting problem. What about other hormones? So I get asked this sometimes. So and particularly is the androgen person, because we're replacing the glucocorticoids and mineralocorticoids. What about androgens? So in men, it's not so much problems because testosterone is often secreted elsewhere, but in women, it may be more of a problem. And many women with adrenal insufficiency describe a decrease in quality of life despite adequate glucocorticoid and mineralocorticoid replacement. So does replacing androgens help with these symptoms? As we discussed previously, indeed, the adrenal cortex produce DHEA, DHEAS, and both levels are lower in women with adrenal insufficiency. So there's been small studies because it's difficult to assess in bigger populations, but they have then piled them all together and put in what we call meta-analyses. And they looked at quality of life. So in adrenal problems, so primary adrenal insufficiency, 50 milligrams of DHEA daily may be useful for improving things such as mood and psychological well-being. Whereas in pituitary dysfunction, it seems to be less strong and there's only modest benefits on the psychosocial well-being. And so meta-analyses of 10 randomized placebo-controlled trials, which is our best way of working out whether a medication does or doesn't work, shows small improvements in health-related quality of life and small benefits on depression, but no real improvement in anxiety or sexual well-being. They also looked at metabolic markers, so things such as cholesterol, weight, and there wasn't really a significant effect between placebo and the actual DHEA treatment. There can be some adverse effects, particularly of excessive androgen replacements, such as oily skin, increasing hair growth, acne, increasing sweating odor, as well as some detrimental effects on the good cholesterol, lowering the HDL cholesterol. There's also not a huge amount of long-term safety data on DHEA therapy. So at the moment, there's insufficient evidence to say that everyone should be, all women who have adrenal insufficiency should be given androgen therapy, and particularly less evidence in men. But in women, if they are significantly affected in terms of their well-being, despite glucocorticoid and mineralocorticoid adherence, then consider DHEA and monitor for side effects. But if there's not been much benefit after 6 months, we would suggest discontinuing it. Sourcing it is another issue altogether. We might discuss this in question time, but it's reliably making sure that it's the right dose is not always that easy. The question on everyone's lips is COVID-19 and adrenal insufficiency. So last year, about this time, there were a number of publications from endocrine societies around the world, particularly this one I thought was quite useful, just going through and just being really sensible about guiding our practice on sick day management in COVID and this year of COVID. So our patients with adrenal insufficiency increased risk of COVID. Potentially there could be a high complication risk and risk of adrenal crisis during an acute illness because there is a general increased risk of increased infection. So patients who have adrenal insufficiency are suggested to really be careful and try to prevent infection. Now, we're very lucky in Australia. We really have dodged a bullet in terms of COVID-19 infections. But make sure that patients are still followed up because it's now 12 months since. And I don't know about you and your relationship with your doctors, but we really haven't seen as many people face to face in the hospitals. We're currently on Amber Alert. And so we are trying to encourage mostly telehealth consultations, but trying to make sure that those are kept up as much as possible and it is really important. Reinforcing sick day management and having those written rules that I discussed before, but also then trying to prevent infection. So maintaining social distancing, ensuring adequate supplies of medications in case of shortages of at least 4 weeks, I think is very sensible. And then if there is suspected or confirmed COVID-19 cases, manage it as with others, but then give some stress dosing. So either oral hydrocortisone 20 milligrams 4 times a day. There is some anecdotal evidence that trying to increase steroid and spread throughout the day rather than stress dosing mostly during the day in the circadian rhythm may be better. So it's sort of evenly spaced. So increasing the prednisone to 10 milligrams twice a day, 12 hourly apart rather than sort of 2/3 of the dose in the morning. If there's any delay in medical attention, give the hydrocortisone injections and really try to seek medical attention. Especially in Australia, there's really no worry about coming to present to the emergency department or general practice if there are any concerns about any illness really, let alone COVID-19. Maintain stress dosing until improved. A lot of you and other patients out there may have concurrent type 1 diabetes, and so trying to monitor and manage increasing insulin requirements would be really important because of the increased glucocorticoids during stress dosing. Continuing regular monitoring is really important during lockdown particularly, and really making sure that we're coming up to over a year now since COVID-19, making sure there is annual checkups of the biochemistry and blood tests and renin and blood pressure and all of that is really important. There are suggested guidelines. It's a very busy slide, and I'll just flash through and you can have a look at that on the recording if necessary. And the other question on everyone's lips is, should I get the COVID-19 vaccine? So as you all know, the rollout has commenced and there's different phases, 1A, 1B, 2A, 2B, and 3. So 1A is all of the border and quarantine workers and frontline health staff, as well as aged care facilities. And then 1B is a lot of other things, a lot of other people that may be listening to this recording today. So adults aged 70 years and over, Aboriginal Torres Strait Islanders over 55, adults with an underlying health and medical condition or disability. And these can include diabetes, severe obesity, chronic kidney disease, heart disease, blood pressure, cancers, chronic inflammatory conditions. Those that are taking immunosuppressive therapy, including glucocorticoid therapy or having chemo and radiotherapy. So a lot of people might fit into the 1B. And Associate Professor Diane Leroy, a colleague and the Endocrine Society of Australia Council advises that some certain hormone deficiency conditions are worthy of vaccine in phase 1B. And the ESA, our society, regards that patients with diabetes, pituitary deficiency, and adrenal insufficiency, including Addison's disease, worthy of vaccination in the phase 1B rollout. Whether it's primary or secondary, they should increase the usual steroid replacement and that what they would do for sick day management if they experience any side effects from the vaccine. Have a chat with your treating doctor and your GP to advise whether it is the right way for you and whether you're phase 1B or whether it's safe to wait for later. By the time you watch this recording, it is ahead of time, there may be changes to the way that the vaccine rollout is going ahead. So do keep up to date and with the New South Wales Health and your local health website. So to summarise what we've discussed today. We discussed the adrenal anatomy and physiology and understanding the different causes, particularly pituitary hypothalamus versus adrenal, and some of the causes. Trying to recognise and diagnose it, and I presented 2 different cases of how this may present. Replacement may include glucocorticoid and mineral corticoid if it's an adrenal problem, and androgens in women who have symptoms despite adequate replacement of the former 2. Sick day management and stress dosing, particularly in the emergency department, is something that's really important. And we also discussed briefly some of the advice with regards to COVID-19 infection, sick day management, as well as the vaccine rollout. Hopefully this has been useful for you and that you have gained some information, and hopefully I'll be able to answer some of your questions now. Thank you so much for your attention and talk to you soon.
So welcome, Vanessa. Great to have you with us. It was a fascinating video. I've got 14 questions here. 14
Awesome. We'll see how we go. Can you hear me and see? Hopefully not see me too well, but hear me okay, hopefully.
Yeah, no, that's fine.
Cool. Excellent.
Great. So I'll start from the first one. Any further comments you could have about the pituitary macroedema and therefore secondary Addison's? That's from Norman.
So I think there was a couple of questions about like hypothalamus versus pituitary versus adrenal and whether there's any differences in their management. There is. So firstly, there's different causes for each one of those things. It's very unusual and rare for all 3 or 2, more than 1 to be affected at the one time. So usually you will find out which one it is. The main difference is how you replace things. So if it is actually adrenal, you need to replace both the glucocorticoids, which is like hydrocortisone, cortisone acetate, prednisone, that sort of thing, plus mineral corticoid. Whereas if you have a pituitary dysfunction, classically, you're not supposed to need to replace a mineral corticoid. So you're supposed to not need fludrocortisone as replacement. Same with hypothalamus. So hypothalamus and pituitary would be sort of very similar because it's sort of a secondary and tertiary hypoadrenalism. But sometimes people do have fluctuating blood pressures and a little bit of fludrocortisone is added for that reason. But it's also important to try and work out what the cause is. So there are a lot of like various medical conditions as well as medications that can cause those differences. So yeah, so if there is a pituitary macroadenoma, I think was that question, then yeah, you would want to make sure that the steroids was replaced adequately and ensure the electrolytes and blood pressure were adequate.
Thank you. Another question, a set of questions relate to androgen replacement in women. And there was a question about whether is there a place for testosterone treatment in women?
So there's a lot of evidence around DHEA replacement, as I sort of said in the talk. Testosterone less so, but we have tried it, and I think it's like we said, there's marginal difference in terms of some of the parameters of studies, such as quality of life, but it's worth it if the person has had adrenal deficiency, and such as with Addison's disease or bilateral adrenalectomies, has adequate replacement of both the glucocorticoids and mineralocorticoids, but still feel not quite up to scratch. I'd try either. For both of these, so for testosterone replacement women, there are some preparation. So in Australia, we're lucky, there is actually a commercially available one. Whereas overseas, it's more difficult. DHEA is even more difficult, like it's only compounded. I asked various colleagues around, there's no other reliable way of doing it. And so therefore it is actually quite variable and difficult. So compounding chemists, like a good reliable one is good, but then there may be difficulties in obtaining sort of regular steady levels. So I think it is still a work in progress. And there's a lot of groups within Australia trying to work on this so that we can get some adequate replacement. The benefit for patients who have secondary tertiary hypoadrenalism is more marginal.
Okay, thank you. A question around the use of pump technology. Is there any benefit of that, and is it very available? Is it something that you would encourage, or is there any research?
So there's some research, Dave Torpy, in fact, in Australia has done some studies on this. The main limitation on this is around the availability. So it's certainly not mainstream treatment because even like, I think the people that have used this have used insulin pumps and infused them in slowly because they're the most easy sort of portable infuser. So we use this technology very commonly in people with diabetes already, type 1, who need insulin. So the idea is that you infuse a slow amount of medication, in most cases insulin, subcutaneously, and you have to change the reservoirs every few days. And then you can also adjust the amount of the dose of medication, in most cases insulin, going in. They go down to like 0.1 mils per hour sort of differences. So it can be quite small. The problem is, even for people with diabetes, they're not funded. So the pumps themselves cost like $10,000, and are only funded if patients have a health fund, or in pediatrics, I think there are JDRF and various funds do help out. And there's a lot of consumables available for it. And so there is no easy way of trying to fund that. We feel generally, I've never personally used it myself. There are people around Australia that have used it, but it's a few handfuls of people, and they're written up as case reports because mostly they're used for people who have gastrointestinal absorption problems, so that they aren't able to tolerate or absorb the oral glucocorticoids that are being taken. So a lot of the case reports are around those, like they've had esophagus or stomach problems and things like that, so they can't absorb the oral doses. So it's a life-saving thing in those cases for patients to have the hydrocortisone infusion. There are various complications related to it, as with insulin pumps, because of the fact that it's very there's a lot heavier reliance on the patient being able to adjust it, troubleshoot should the pump fails, because they always fail. So this is the same for people with type 1 diabetes as well, and infections, because it is something sort of being infused in rather than a tablet that you take. But you get the same problem with failure of oral absorption as well. So people, when they get gastrointestinal infections and things like that, the oral glucocorticoids aren't being absorbed, and therefore that is also a problem.
Okay. Thank you. I guess to continue that idea of technology, there is talk of an injector pen for the Solu-Cortef. Any updates on that one?
I love it. I haven't seen it. I think that what we've got is suboptimal, and I keep saying that to patients, but I think, I mean, in this group, there might be people already with that second cause of adrenal insufficiency. So there's heaps of people going on to these checkpoint inhibitors, and lots and lots of people with hypophysitis needing this. So I'm seeing like several new patients each week refer to me from the oncologist with this. So hopefully it's with these increased users and prescription, hopefully there is new ones around, because it is actually quite a challenging pen to teach people to use. I've got all of the little, you know, tester kits, and then you have to go get a needle and a syringe. There is a lovely video that the endocrine nurses have put together that I'm sure most of the people on this site have seen. But still, it's like in the heat of the moment when you actually need to inject the thing, it's like quite difficult. But it is what we have at the moment. I think and I've spoken with various people to see if we can improve the quality of these injections. I haven't seen anything, you know, approved or out yet imminently, but hopefully they'll work on it. At least something as easy as like a glucagon pen, which we again use very commonly for people with diabetes. Is in one device, like the syringe comes with a saline that you inject in, like without having to have separate bits and pieces. But we'll see.
Why is fatigue an ongoing issue, even though medications are all adequate?
So I guess it goes back to the fact that everyone's absorption and metabolism of the synthetic versions of the glucocorticoids are slightly different. And there's also no great way of measuring whether you've got adequacy of replacement. We're always harping on about, oh, we need to make sure that we don't excessively replace at baseline and then give stress dosing. It's kind of confusing for a lot of treating doctors as well as patients themselves. They go, well, how do I know whether it's correct or not? You can do cortisol levels, but hydrocortisone, cortisone acetate are similar enough to cortisone. You can do a prednisone level, but it's cortisol. If you measure cortisol after prednisone use, it's not exactly the same, and everyone absorbs it slightly differently as well. So it's that whole balance of trying to make sure that you don't over replace, so that you don't get the long-term side effects, but then also making sure that you get a enough. The endogenous, like the one that you secrete yourself, is pulsatile. So I showed the graphs of what it looks like, but it's never exactly like that. And I suspect none of the preparations we've got are perfect. It's not bad, but none of them are perfect yet. And that's, I guess, why it's not exactly the same as your own. In a minority of people, maybe because they're needing tweaking of the other hormones, so particularly for adrenal causes where the mineralocorticoids are adequately replaced, and androgens. I think there were also questions about whether adrenaline and noradrenaline need to be replaced, because that's what's in the adrenal medulla in the center. That's very rarely a case. So it's only in people who have genetic mutations, because the adrenaline or noradrenaline, even if you take up both the adrenal glands, won't need replacement. They're secreted elsewhere in the sympathetic system. So they don't need replacement, even if you've had both the adrenals taken out.
Okay, I'm going to follow on from that idea of pulsatile delivery of the natural system. Is there a way that we can do this within our own system, either through continuous, having some pulsatile delivery, for example, a combination of hydrocortisone and prednisolone, your long-acting and your short-acting? Is there any benefits in doing that as opposed to just your continuous delivery like we've got in our normal treatments?
So I tried out with lots of people, and I think one of the other questions was, right, do I use hydrocortisone, cortisone acetate, or prednisone? It depends a little bit on the situation, the individual, and the person. So for patients with Addison's, the teaching has always been go the short-acting guy and just go hydrocortisone. And it's mainly because of the fact that you then have less steroids overnight when we normally would have very little, so that you're not suppressing your bones. Patients with Addison's, like the pure Addison's where you have adrenal failure from an autoimmune cause, often occur early, like they occur younger. So you've got a lifelong replacement of steroids, and we want to try to be on the lowest level, hence the hydrocortisone or cortisone acetate 2 or 3 times a day. The older patients that have oncological causes, so the immune checkpoint ones that I'm seeing more and more of, I often use prednisone because, and pituitary ones, a lot of it, they've got a lot of other chemo treatments going on, and a once a day prednisone suits them well because they're often on it for, they've been on it or could be on it for other conditions like other immune related adverse effects. I have, though, then moved off those treatments if that individual, it didn't work so well for them. So I get them back within a few weeks, 6 to 8 weeks, and say, you know, how are you feeling yourself? And they can call me early if it doesn't work. if it fits. So some people, it's a genuine thing. They've done studies looking at metabolism absorption. Some people just do not absorb prednisone for a long time or metabolize it very quickly, and therefore the prednisone doesn't work. I've got some patients that are on a combination of hydrocortisone and prednisone. So the prednisone lasts long enough for them that they don't need to have the multiple doses that they don't want to keep taking, but the hydrocortisone works fastest for them. So they take both of them first thing in the morning as soon as they can. The hydrocortisone kicks in faster for them and the prednisone lasts longer for them. So they just take that once off dose first thing in the morning.
I'd just pick up on the point that you make that a lot of people who have the primary Addisons get it when they're young, but I think there's quite a lot of women here and men who have got Addisons in their older age and it's still autoimmune, so there's no oncological cause. So what would you say about that then?
The teaching still is out there that you're meant to be trying the short acting 2 or 3 times because of that particular reason and its effect on bone. But I'm quite pragmatic and I say, look, you know, what suits you and what makes you feel better. And so I start off with the one particular option, but I by no means stop on that. I don't stay on just one particular dose. The amount that you're supposed to need is a little bit gender and weight dependent. So a heavier person will need more, a lighter person need less, but you start off with that and then you know, tee it up and down. We have to also make sure that we watch for parameters of like complications. So I look at glucose levels, lipid levels, watch the blood pressure, weight, and what side effects they might develop as a result of all of this. So those things are all, I think, quite important.
Okay. There's some questions around the vaccine, obviously, and so thank you for covering some of that as part of your presentation today. There's one question around whether the rare clotting, blood clotting of the associated with the AstraZeneca vaccine, it's an immune response, and therefore are we perhaps at higher risk of having the same sort of immune response or an immune response that's leading to the rare blood clotting?
So the honest truth is it's still very early in the beginning of all of this, trying to work out what it is. I speak with one of the hematologists at my hospital and asked them about this because I went, we were talking about this talk, and they're meeting once a week to try and work this out from an Australian point of view as more and more cases come in. We don't know, and there's currently from the Endocrine Society no contraindication for anyone with autoimmune disease in taking the vaccine, because I think we're very, very lucky in our situation in that we've got like pretty much zero community transmission anywhere in Australia, and we've got a bit of vaccine hesitancy, and I think we're all like realizing that might not be the best way to go because of the potential of leaks. Like the hotel quarantine's not gonna, like there's leaks coming out from there, and they've tried to ring vaccinate the healthcare workers around them and the quarantine workers, but we can all be standing in the supermarket queue next to someone that could have COVID and not know it. So I think it's that balance. So we don't actually know, we don't think so, but there seems to be someone there seems to be, certain people that develop this clotting issue, and some, but not all, have a particular platelet-derived antibody similar to HITS, which is that heparin-induced one. It's sort of like that, but not exactly the same as that particular condition. And so, so each week we're learning more and more about it. Most of the cases that have been reported overseas, you've seen journals have scant details about the actual clinical aspects because they're trying to, talk about the big picture. As some of the Australian cases are being looked at more closely by the TGA. I think we'll know more information, but at the moment we're encouraging people that are at risk, so have chronic conditions, including hypoadrenalism, to be vaccinated. And so those that are under 50 will be able to access the Pfizer vaccine, and those over 50 at the moment, the AstraZeneca vaccine.
And so you have no preference for either?
You get what you have available. I think the risk of complication related to getting COVID, still, even though we have so little transmission, they're going to open up the borders at some stage. And so I think we have to be prepared for that. This is as good as we're going to get it. I mean, as we've all seen, this is as good as we're going to get it for several years, because they will open it up, and then we have all to be prepared. And I think it's an individual choice as to what the person decides to take. I have no preference, and I think people have to get what they can get locally. So if you're under 50, you'll have available anyone that's on call now that have hypoadrenalism who's under 50, you can go and book in to get a Pfizer vaccine, and it's not a huge wait, honestly. I think it's like 2 or 3 weeks max for most places, like for the longest time, and over 50 Astra, but we don't have
Okay, so a question then, moving away from the AstraZeneca and the Pfizer options, and maybe moving on to some just general management questions. So what if you forget to take your cortisone? For example, you might have it a few hours later. Are you at risk of having a crisis, an adrenal crisis, if you forget?
I think it very much depends on how long and whether there's any other comorbidities going on. So honestly, most people will feel it by lunchtime if they've forgotten their morning dose. I think that's the truth. And a few hours generally is not going to make a huge difference. And adrenal crisis usually is only when there's some other intercurrent illness going on. Classically, it's the food poisoning, gastroenteritis that people get on top of the adrenal insufficiency. And I think that's the difference. Yeah, so generally it's they're not going to go into crisis if they just miss the dose. Just take it when people remember it.
Okay. Another question's just popped in about the effect of emotional stress and physical stress, and how that can actually cause a problem. And I know that some people are told that that actually isn't going to cause an issue, and they're not encouraged to stress dose in those situations.
Yeah. So I think that's why it's important, like, you know, what we talk about is general, and you've got to talk about it sort of to each individual. On the Hormone Society, so the Endocrine Society of Australia sheet, it says, you know, under emotional stress, you generally should not need to stress. I do sometimes say they could stress. So to me, it depends a little bit on how much steroid replacement they're on. So especially the people who are deliberately going like to the lower end because of avoidance of long-term side effects, which is perfectly good. So if they're on, like, you know, 10, 14 milligrams of hydrocortisone or 2.5 milligrams of prednisone, I find definitely that when they have like significant emotional stress, it does require a bit of replacement. People also ask me, not uncommonly, hey, what about if I'm exercising? Do I need to increase the stress dose? And I go, oh, you know, what sort of exercise are you doing? It very much depends on the individual. So it is always about trying to balance the side effects and the stress. And I always go, you know, what's the point of taking these steroids if you've not got good quality of life? Because to me, I think that's the most important thing. And it's balancing the quality versus some long-term, you know, complication. But we need to just watch all of those things and see. So I do sometimes suggest a little bit extra, but not for a long time, I guess. If there is a patient with significant bereavement, they have to stress dose. Like, it's not fair and it's not reasonable for them not to stress those. So I do sometimes, but we sort of say, you know, exam stress, a little bit of that, you know, minor stress if they can. I also suggest not maybe stressing to the full double or triple. And I think, but it depends on the individual. And I think this is where sort of it's difficult. The sheet does say specifically, you know, talk to your clinician about your individual, you know, circumstance, because I think it has to be an individualized process.
Yeah, and certainly the comments coming through the chat and personal experience and knowing people, emotional stress really does have a huge impact.
Absolutely, yeah.
So on that, in terms of managing that, then, so I take prednisone, for example, and I know other people in our group do, and I know that some people who are on that, they might actually use hydrocortisone to actually stress dose rather than up their prednisone. I don't, but some people do. So is there any sort of general thought around how you can mix and match your medicines depending on the situation and what's needed?
It depends what it's on. The short-acting guys are meant to be a bit better, but it depends on sort of the duration of your stress, I guess. I think somebody's talking about like exercising and things like that. Yeah, I had a guy literally say, oh, you know, should I, you know, do it when I'm exercising? I went, no, generally not if you're just doing your usual exercise. But this guy's like a marathon cyclist and he's like riding like kilometers and kilometers. I went, yeah, you should. Like, that sounds like a significant stress on you. So I think that, yeah, it varies. So you basically have to just understand how your own body feels and reacts, and also the duration of what your likely stress is, especially if you can try and plan for it, and then the duration of the medication. Because like you say, prednisone, if you take a big dose of that tends to hang around a lot more, and then a lot you're a lot more alert at night, which then defeats the purpose of sort of the stress dosing. You're tired, you haven't slept, and then the next day you feel horrible. So trying to use the shorter doses to stress dose is a reasonable thing, but you've got to sort of have it around and have sufficient amounts of it and have an understanding around the stress dosing. So it's certainly something that you can talk to your a treating doctor about that.
I mean, the other thing around stress is that it can be delayed a bit too. You can be right in the situation, but it's a day or two later when you can actually feel the effects of it.
Yeah, for sure.
There's I guess following on from that, there's a question around people celiac question, for example. If they had a gluten continuation, can that be lead to an adrenal crisis, and so should they stress dose in that sort of situation?
I don't quite get the question. So if they have a
meal that had gluten, okay. So if
they have celiac but they ate gluten, oh, I mean, we're advised not to. It's not supposed to be a huge deal, but some people react really pretty badly after they've had gluten, like mistakenly, if they've got celiac. So yeah, I wouldn't get it past them, like particularly people who like get pretty bad GI side effects. So in those cases, you'd stress dose like you had gastro, because like even with copious diarrhea, you're worried that the transit time of your medications going through quickly and you're not absorbing the full dose. So it depends how you generally would react to the gluten if you're a celiac. That's what I would suggest.
Okay. Di's raised the question of whether, rather than having high zone or hydrocortisone stress dose, whether you actually should increase your Florinef to deal with the electrolyte loss.
So you can. So generally for that, the Florinef increase, I generally suggest if there's some excessive fluid loss. So hot days, people are, running marathons, that sort of stuff, they can. They're feeling a bit dizzy. Don't do it for a prolonged period of time, but stress dosing is reasonable. But generally the stress dosing is around the glucocorticoids, because it's the glucocorticoids that is the one that's meant to be propping up blood pressure, heart rate, glucose levels, but the mineral corticoid also has. And like I say, this is mainly for people who have adrenal insufficiency versus pituitary hypothalamus. That's meant to be like preserved, but honestly, mix and match. I think it's got to be individualized. Like it's got to be depending on the particular individual. But yes,
okay,
that's generally correct.
So if another question around the idea of, if we're just replacing, then why do we have these other symptoms and why they continue? And one of those is weight gain. So some people really do have an issue with weight gain, not just going back to their normal weight after they've been diagnosed and get on track, but some do continue to struggle to continue.
So I find it very difficult. So another little subgroup of people with adrenal insufficiency, such as people who've been on long-term steroids for, and there may be people like that in the group now, who've been on it for polymyalgia rheumatica or for asthma or rheumatoid arthritis, some other as an anti-inflammatory, try to decrease it and they just cannot get off it. For that, and sort of for people who've been on high doses, it may be that the body gets used to a higher dose of glucocorticoids, but that increases a few things such as changes your metabolic rate, increases appetite, and does make people put on weight. And like I say, it's never exactly the same. Like the actual cortisol that's being secreted by an individual is like lasts minutes. So there are periods of time in between where there will be no glucocorticoid, very, very low levels. So they've done this on like cortisol day curve. So they can track these poor patients or subjects that are getting their cortisol drawn every 5 minutes. I'm surprised it's not high the entire time. So I think they do, they have a line and they just quietly draw it without sort of stressing them out. And they're, and cortisol levels can vary from minute to minute quite significantly. And so whatever we give patients, the shortest is like hydrocortisone, cortisone, that still lasts 4 or 5 hours. And so therefore the amount of steroids being given to a patient is still going to be higher than what they could have secreted endogenously. And I think until we find sort of a better version of trying to do that, it's not going to be exactly the same. And I think that leads back to one of your original questions about the pump. Is that, good or bad? But yeah, so that's the idea, is that a continuous amount that varies will be good. But you also then have to have some way, how do you sense how much stress, how much steroids you need to be sort of infusing in? That's sort of the question also.
So do our bodies need, is our body that responsive to our environment and our situation that it it triggers the release of cortisol that immediate. So if I'm in a sudden stress situation,
so it does
suddenly
go up
release
reasonably
it.
quickly. Yeah, it's sort of it's meant to like respond reasonably quickly. Like, so they've done all sorts of studies looking at, you know, various stress situations, because, you know, even now we don't really know how much stress dosing we're supposed to give. So people always, like doctors always going, oh, we've got to give the least amount because glucocorticoids can lead to infections. So should we stress dose with so much around the time of operations and infections and things like that? And so they've done studies looking at people under different types of stress conditions. I think it was like last year, maybe, in clinical endocrinology, where they had people in like sort of war situations, people in surgery and short versus long surgery, and people under sort of other types of sort of physical stress, and seeing what their glucose and cortisols are. They did sort of, you can only sort of sample them so many times for those circumstances, but they've done like sort of normal subjects under no stress. And yeah, it can be quite variable, and it's a pulsatile release, because cortisol is got a short half-life in the, like the actual cortisol. And so whatever we replace is never going to be exactly the same as that. And so we try to give you enough so that it's above the minimum level, like the peak level, but then there will be times when the drug that we take is going to be more than what you actually need. But then you still feel tired and you go, well, the fatigue can be multifactorial. Like, we don't really know, you know, what all the potential causes are. Is it that we have got too much? Like, too much can sometimes cause muscle aches and pains and so on as well. That not enough because we're used to a higher dose, all sorts of things can be possible. It's really hard to tease out. Like, I think it's in endocrinology, especially for me, I go, right, I want like a thing I can measure and say, yep, that is or isn't enough. But, you know, there are prednisone levels and cortisol that we can measure, but individuals on how much they need is variable.
We've got some questions around cholesterol and high cholesterol. Is that associated with Addison's?
It's associated with sort of more thyroid. So I think, yeah, that's a more likely common association. But if you have excessive replacement of glucocorticoids, that can make you more have the metabolic syndrome, which includes high blood pressure, cholesterol, that sort of that whole syndrome. So I do check it in people, because I think it's one of the things that we can correct and watch and change and modify with our diet, because it's about sort of that, like looking at the short term, how you feel, but then also long term, making sure that we address reversible causes of, you know, complications, cardiovascular outcomes and things like that.
Now, Elizabeth's asked, do you ever recommend 12-hour or 24-hour day curves?
I don't generally, because unless there's a specific reason for it. For the individual general person, I wouldn't think that that was necessary or super likely to cause improvement in their management. So I only think that it's useful if it's going to actually make some difference to their own treatment.
Okay. And we've just, if you could just outline again what those common side effects might be for long-term medication use. So for example, does stomach issues come to that? You're sort of hanging around, you're sort of flying around in the ether there. You're on mute. Okay, let's got it. Nope. Okay, Venessa, you there?
Okay, are you hear me? Can you hear me better?
Yeah.
Okay, that's good. So basically, yeah, so the main thing is we don't want to excessively give patients glucocorticoids because of the fact that it can increase weight gain, can cause increased blood pressure, increase bone loss, so watching out for osteoporosis. So I do check bone densities in people, especially if they've had a family history or previous fracture risk. And diabetes is another thing that I watch out for. So not everybody gets all of these things, but obviously it's reversible and things that we can screen for. I watch out for cataracts, so excessive replacement corticoids can accelerate formation of cataracts. And then those are the things that we can screen for and watch out for. You can't avoid all of those things, obviously, but the things that you can less commonly avoid are the thinning of the skin, easy bruising, that sort of stuff that I think a lot of people may experience. But generally, there could be signs that there could be, you know, excessive glucocorticoid replacement.
Okay, so when you say excessive, does that mean maybe 5 milligrams more than what you should be on, or does that mean 20 or 30, you know, yeah. So we're just wondering how fine-grained we need to be looking here.
So because the amount of glucocorticoids that need to be replaced varies depending on the individual. So it's not so much around the, you know, how many milligrams excessive, it's what the person needs. And a person's requirement varies. So like I said, it's a little bit weight dependent, but you need what you need basically. So you want to try and drop it down to the lowest level at baseline, but also not be worried about giving stress dosing when required. Yeah.
All right, thank you. Okay, I'm just looking at what some of the other things are. There was one around type 1 polyglandular and type 2. Is it possible to have both, or to have both?
So there's a constellation of different things associated with one. They know which the gene is, and 2 is the one where they're not, like there's polygenes, like there's multiple genes available. So that's why they're sort of one or the other. Type 1 generally will be associated with this fungal thing, mucocutaneous candidiasis, so it's more likely, and they often will have the hypoparathyroidism, which is reasonably rare outside of type 1 polyglandular and surgery, endocrinopathies, whereas type 2 is, I think, a lot more common, where you see it with very commonly, like I think a lot of people will get associations of people with thyroid dysfunction, celiac, Addison's, the whole, you know, full shebang. So
a question you mentioned just before about diabetes potentially being one of the side effects of, or the outcomes of having elevated doses. I know that a number of people here have got diabetes. Is it possible that might have been because if they had Addison's first and then they got diabetes,
so
that happened for me, for
type 1 diabetes, so type 1 diabetes is genetically associated with Addison's because of it's like the type 2 polyglandular endocrinopathy. So those patients would present often very dramatically with like 0 insulin levels, maybe in ketoacidosis, and actually needing to be on insulin straight away. The diabetes that I'm thinking about with regards to a complication of glucocorticoid treatment is insulin resistance, type 2 diabetes, where they actually can go onto tablets to begin with, and then can go on to escalating treatment after that, potentially insulin down the track, but not immediately. So there's a lot of people, so there's a lot of research out there for people that are overweight but don't get diabetes, and vice versa, that type 2. So it's not ever just one thing, and I suspect there are, you've got to have a little bit of, like if there's genetic predispositions for it. So there'll be some people that have unfortunate genes that and a family history where they're going, you're more likely to get type 2. Those people, you really try to strictly address the lifestyle changes you can try and modify to prevent them getting to that point. But honestly, sometimes you just need the steroids because you need the steroids, and some people really do get a lot of stress dosing required because they are getting sick from a lot of reasons, and so that predisposes into getting diabetes. Fortunately, we've got good treatment for all of it, and you know, it doesn't have no longer does it have sort of a, you know, long-term consequence of being diabetic or Addison's, as long as it's, you know, well managed.
Okay, we've got a question around the fact that Addison's, we're not likely to go into remission, are we? And if we're not, then why do we need to have the constant testing, you know, the fasting tests and those sort of things, just to check on things? What's the purpose of that monitoring?
It depends on what the cause of your hypoadrenalism is. So if it is actually like autoimmune Addison's, I don't keep testing the cortisol for the sake of seeing whether it is actually there anymore. I test aldorenin to see whether the adequacy of mineralocorticoid replacement is good, and I see them at least once a year to make sure that we reinforce the stress dosing and see how they go, whether the doses are right. Because I do find that as people age, there are changes to their requirements of the steroids because we all change, like, you know, including sort of weight changes, but, you know, circumstances, women going through menopause, I think there may be impacts on that. And all of that I think is sort of still not sort of fully acknowledged and worked out and seeing. So I think for those reasons I do see people, but I don't know necessarily that, you keep testing for it. However, if a patient's got hypoadrenalism because they were on high dose steroids, I keep watching it to see whether it can recover, because you can test the autoantibodies, right, for Addison's. If they're not there, there is still a chance that they maybe have recovered adrenal function, and that would be great, because being not on steroids would be fantastic, because they don't have to be so worried about all of the complications related to being on steroids.
Okay, thank you. So how common is osteopenia in younger Addison's patients? There's a number of people interested in that. And what are some options for bone stabilization?
So you don't know until you see. So we see it in people even outside of Addison. There are a number of young people that have osteopenia. You're going, oh my goodness, where does this come from? Some of it is genetic, so there may be a family history of it. Your bones are related a little bit to your body weight. So there's a lot of Addison's people who are young, healthy, and maybe of slight weight, and they may have osteopenia. In us fabulous women, I think pregnancy and breastfeeding is also a well-known association with a dropping bone density around that time. So all of these things can have an impact. So everybody should stay as active as they can. So from the time, our kids, grandkids, everyone, they should stay active, because if we're inactive, we won't reach our peak bone density potential in our 20s and 30s. Having a good calcium intake is really important. So 1,000 to 1,200 milligrams of calcium per day. So a glass of milk is about 300-400 milligrams. And you're going, nobody's drinking 3 glasses of milk a day. So a lot of people will not have that. There are a few other foods that are non-dairy that can contain calcium, and that may be useful. And having good levels of vitamin D is important, because it helps you absorb the vitamin D more appropriately. People with Addison's are also more likely to have other associated conditions that can affect the bones, such as parathyroid and thyroid dysfunction. Celiac disease can also affect absorption. So the simple things are the lifestyle changes, calcium, vitamin D supplements. There are pharmacotherapies, but we would, in younger people, need to sort of counsel them more appropriately and make sure that they understand what the implications of that are before starting it, particularly if they're thinking about starting families.
Yeah, and actually one person's just indicated that they had a baby last year, which might have contributed to them issues there. So I guess just to follow up then, the issue of calcium supplements is a bit of a contentious one amongst practitioners. I know that some say that you shouldn't have it. It causes heart problems, and where you've just indicated that actually that might be quite a useful thing to do. So
it depends. So if there is some reason why a person has gastrointestinal absorption and are not getting sufficient calcium, and they're already kind of proven of osteopenia, osteoporosis, or at risk of it, and taking up to 600 milligrams of calcium, particularly in addition to vitamin D, is not associated with increasing vascular risk. It's a theoretical risk that has borne out in some of the larger databases retrospectively. So they look backwards at GP databases and say, ooh, there's an increased risk of vascular disease in people who've got excessive replacement of calcium. But it really is not a risk if you're taking vitamin D supplementation, and I think up to 600 milligrams. They've done even studies, like Endocrine Society members have done studies where they look at poor subjects taking calcium immediately and then measuring the calcium levels in the blood, because it's a risk of taking calcium and then your blood levels increasing significantly for a short period of time and then depositing in the vessels. That's what I guess they're worried about. And it really doesn't, it doesn't increase that rapidly to cause vascular complications. Long term, I think excessive replacement is no good. So I generally say to people, especially if they've got gastrointestinal malabsorption, up to 600 milligrams is good. Diet's always better. So if you can tolerate diet, that's great. But there's a lot of people that are lactose intolerant, and other sources of calcium are often much lower levels, and you're not going to meet that. So so it's trying to balance probabilities and risks of all of those things and seeing which is the best option.
Okay, so it's really not an accurate science. It's really just about working out what it is for each of us, and
I think exactly, personalized medicine, right? I think that's got to be the way, that we've got to individualize the person and not just saying one size fits all.
Okay, well, look, thanks so much, Venessa. We do have to stop it there, and thanks everybody for putting your questions in the chat.
Hello everyone. Dr. Tsang, this was a most enlightening address, you seem to know so much about our condition and where we might be going and where we might have come from. Thank you for your thoughtfulness and your quick thinking. I'd like to thank everyone for coming today, and I'd particularly like to thank Linda for her quick computation with our many, many, many questions. Dr. Tsang, I think you could be here till 6 p.m. Thank you, Linda, and thank you, Di, as well. A most informative afternoon. I would like to suggest to everyone that if you wanted to stay on for a little while, we're not going to shut off immediately. So if you had something you wanted to tell us or something you wanted to ask us, you're very welcome. And I do notice that lots of people are thanking Dr. Tsang on the chat.
Can I say thank you very much to you for the invitation, because it's always invaluable for me to hear questions from patients. I think we don't, as doctors, don't do it enough trying to work out, what information you need. So yeah, so we're all working towards doing that. But thank you very much for the opportunity. I appreciate it.
But it's wonderful that you're so open and prepared to listen.